ये तो है ही।
Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day and Beam NAMS, NAMS Task Forces, aims NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, Scientific Visit of Emeritus Professor and many more activities. All application forms for Fellowship, Membership, Associate Fellowship, and Member After Day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22nd January 2023 by the NAM's president, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and welcome everyone to the next session of online NAMS Navigate Medico CME program. Since we all are attending the series of lectures on chest medicine and tuberculosis by Professor Rajendra Prasad sir. So today's topic is of very unique importance since we all know and we all have been educated through previous lectures that tuberculosis is one of the major health issue in India, and India is the country with highest prevalence of tuberculosis. So it's very important to diagnose it at the earliest for a proper management. And for the diagnosis, out of all modalities, radiological modality is one which gives us the earliest confirmation, or we can say the clue of this deadly illness. Other tests like acid fast bacilli, uh, smear, or we can say sputum microscopy, or CB naught, or other tests, they take time, and at times when the sample is not adequate or is not uh, collected properly, so it may result in negative it may result negatively. So chest radiology is still, since ages and even till date, this is one of the very important modality which we all need to learn, and this is very important for all the peripheral doctors, mainly are doctors who are serving at the community health centers and primary health centers. So continuing session, I would like to now invite Professor Ajay Kumar Sood sir, Deputy Secretary of National Academy of Medical Sciences, for the welcome address. Over to you, sir.
Thank you so much. On behalf of the National Academy of Medical Sciences, it is indeed my great privilege to welcome the distinguished speaker for this session, Professor Rajendra Prasad sir. Sir has been our senior council member as well as the NAMS fellow, and all of you are familiar that he has been taking the series on tuberculosis. So welcome and thank you, sir. And I would like to mention here that sir is one of the few person who has worked in tuberculosis since late 1970s, more than 5 decades of experience. So it is really, we are really honored to have you, sir, for this series, and kindly you agreed to take session for our PG student right from the month of April. And today is the last session, as Dr. Jaswant says, on tuberculosis. So welcome, sir, and we are really grateful to you for your support to the academy. I will also like to extend warm welcome to all the participants, our faculty members, and our PG students. For PG student particularly, it is a unique opportunity that you can interact with one of the best person in the area of tuberculosis in our country, as well as outside the country. So please make best use of this opportunity. You can send your question and queries in the chat box, and sir will be happy to answer that. So welcome, and warm welcome again to Dr. Jaswant for kindly agreeing to moderate the session. So with these few words, I welcome you all. Over to you, Dr. Jaswant, for introduction of our distinguished speaker.
Thank you, sir. So as we all know, Professor Rajendra Prasad sir is a well-known personality in the field of medicine, and his achievements are so big that he need not introduction from for anyone, but I would try from my side to briefly introduce sir. Professor Rajendra Prasad sir is currently Director of Medical Education and Professor of Respiratory Medicine at AIRA's Lucknow Medical Colleges and Hospital at Lucknow. Sir is also emeritus professor at National Academy of Medical Sciences and has held the position of director at VP Chest Institute and UP Rural Institute of Medical Sciences and Research. Sir has been awarded with numerous awards, a long list of awards, including the prestigious Dr. B.C. Roy Award for developing pulmonary medicine in India. Sir has published more than 600 articles, book chapters, and reviews, and supervised more than 215 research and theses. So, with this brief introduction and without wasting much time, we all are eager to hear to you, sir, and just to learn from your teachings. And, sir, we all know that sir has been a very passionate teacher, and we all are privileged to have you, sir, uh, as a speaker. So, thank you, sir. Over to you, sir.
Thank you, Dr. Jaswant, and thank you, Dr. Sood, for inviting me for this lecture. Though probably this is the fourth lecture I delivered in the chest medicine, and this is going to be the last lecture of this series. And so, at the outset, very outset, I wish to thank the National Academy in general, and particularly Dr. Sood, Dr. Kapil, Dr. Bera, and Dr. Jaswant for giving me this opportunity. So today, just I would like to share my slides. Screen share, क्या करें हम? ये So I hope my slides are visible. Jaswant?
Yes, sir. Slides are very well visible and you are audible, sir.
Okay,
Sir.
thank you.
Thank you, sir.
So the topic today is a very, very common topic, which I believe everybody has to see for. Everyone has to look for X-ray. And in India, as Dr. Jaswant and Dr. Sood said very rightly, tuberculosis is a very common problem. So that's why I chosen this topic, just radiology in pulmonary, especially pulmonary tuberculosis. And when I start any lecture, I usually start with this quotation from APJ Abdul Kalam Sahab, that if you want to shine like a sun, you have to first burn like sun. Since many of the PGs are attending, so I just chose this thing to say them that during your PG life, you have to be very hardworking, and how much hard work you do will depend upon your future career and future reputation. And well, I can tell you that my life itself started way back in '89 when I was lecturer in KGMC, and I went to Japan on a WHO visit for about 3.5 months, and I saw the world. Literally at that time, Tokyo and Osaka were one of the very developed places, and I saw those departments. If I share one line about these institutes where I worked, in '89, I'm talking, I worked in a chest hospital, and there were 2 departments of lung cancer in that chest department. So when I came back from Japan, in India, in KGMC itself, and then we developed thoracic oncology, and we changed many of the scenario of tuberculosis into pulmonary, into the critical care medicine. So all those changes I have been able to do it because of one of this were my initial training at Japan. And then I have been initially trained before that in KGs, and I worked in KGs, and then SAFI, then Patel Chess Institute as director. My last 3-year stint in the government has been, and now currently I am working in Lucknow Medical College, plus 10 years literally. And I usually start my lecture with another proverb that, and this I learned from Japan itself, that better than 1,000 days of diligent studies are one day with great teacher. I'm not saying that I'm a great teacher, but I said these words for my mentors. But there has been many mentors of mine, starting from Lucknow to even to Delhi, and I learned from them. So since this is a radiology workup, so I would like to show you one of my YouTube lectures is on the chest X-ray interpretation. And that was, by this time, I have been seen by about 3,70,000. Since then, many of the students is calling me YouTuber. So I'm not a YouTuber, but this lecture has been very popular over time. And any of the PG students wish they can go through this YouTube presentation and then we have a book on chest radiology, manual of chest X-ray. This is all on the demand of my old UG and PG student whom I taught for last 50 years. And they have always said that you have taught chest X-ray to us. Why not have some hard or soft copy of? That's why this YouTube lecture and this book, that was the genesis. And what I will do for next about 45 minutes, I believe I have 3 things in my mind. Initially, quickly in first 10 minutes, I would like to say how one should approach to chest X-ray. And the next part would be what are the common presentation of chest X-ray presentation, especially in pulmonary tuberculosis. And then for last 10 minutes, I believe 10 to 15 minutes, I will share some of the differential diagnosis of pulmonary tuberculosis, where they sometimes they are misdiagnosed. And I usually say that kilos and quintals of ATT are misused in a non-tuberculous condition, which mimics tuberculosis. That is why the last part I put as a differential diagnosis of pulmonary tuberculosis. So first part is how to approach. And when anyone sees, and believe me, everyone has to see chest X-ray. Not only the chest physician and physicians, everybody may be you specialist, super specialist. One has to see. And when we see the X-ray, always in our mind, whether X-ray is normal or abnormal, that is the first question comes to our mind. And then if it is abnormal, then what could be the abnormality? That is always in our minds whenever we see X-ray. And to answer these questions, I always say that there are 2 approaches to look on chest X-ray. One approach is known as systematic approach. When I say systematic approach, read the chest X-ray systematically before finally interpreting. What happens, it means I will tell you one system. You can have your own system. But the bottom line of systematic approach is everything visible in the chest X-ray, you must look before you try to make an opinion about chest X-ray. That is what is known as systematic approach. The another approach is a global approach, which many of us have. If my PG comes, he just sees first what is the abnormality. That's a global approach. But in global approach, what is said that you see abnormality first, But then you see rest other structures available in the chest X, seen in the chest X. Then you come in. Both the approaches are same, but it is how you go ahead. And I usually say that for PG student or for young faculty for 10 years to 15 years, you should have a systematic approach if you really want to become a good chest X-ray interpreter. If you ask me, sir, which approach you have, of course, at this stage, I have a global approach. But I know that if I'm seeing this type of shadow, what else I have to look? But probably a beginner may not know this. That's why you might commit mistakes. So that's why I always say that you should have a systematic approach for first 10 to 15 years. In a systematic approach, it's not the anatomy point. It's not only bony case, soft tissue. It is the technical points are also very important. So there are two issues in systems, technical issues and anatomical issues. In technical schools points, what you see usually is you say that chest X-ray PF, these are technical points. It is plane or contrast. What view is there? Is there rotation? Usually what happens, two important issue in technical points, what I learned in my life is, one is rotation. Patient usually when X-ray is done, although he has to stand direct, symmetrical position, but it not happens every time. So rotation, why you have to look for rotation? Because rotation may create a certain false finding, which is not in fact there. So that you have to discount if person is rotated and you are trying to read that film. Exposure is another issue, but not very common issue today with the digitalization of the X-rays that you can control. And another point is inspiratory and expiratory. You know, X-ray, chest X-ray ideally is done in full inspiration. But many a times patient is not able to understand the instruction given by the radiographer, and so film may be done in expiratory phase. We see many times as a clinician. So that makes a difference. There are a lot of difference between inspiratory. So these are some of the technical points which are very important. And for examples, and in anatomy, what you have to look? You have to look for soft tissues, for bony case, trachea, diaphragm, heart, hilum, mediastinum, fissures. Then you have to go. So lung parenchyma is the last to see. But in a global approach, usually findings are mostly in the lung parenchyma. So you see the lung parenchyma first. That is the difference. So these are the issues which you have to see. Now you see the technique. I like to take one or two examples which you must think that it is also very important. Your technical points is side is determined that which one is left side, which one is right side. You know, on the left side there are fundal gas shadow. The apex of the heart lies on the left side and aortic knuckle is on left side. That is how you recognize. But in some difficult scenario, it is not possible to recognize these structures. Then I say marker on the chest X-ray plate is most important. Because you know, marker is put where X-ray is being exposed. So hardly there will be any defect in putting the marker. So that is known as very important. And you know, this I still remember some of my PG when I was in KGMC came to me with this X-ray and complaining about the technician. That the technicians are not working properly. You see, they have written the name wrongly. I said, you may be right, but see why he has written the name wrongly. Why this? Why is this? Why the date is written? Why the date is written? I have removed the name. Why the date is written wrong? And that was very point about it. When we see that this was in a case of a situs inversus. This case was the situs inversus. And how you recognize situs inversus? It is the marker. Here it is a left. It means this is a left side. If this marker would have not been there, then whatever the way the name was written, that may be right. But now it is right. Now the dates are proper and because of the situs. So these technical issues are sometimes becomes very, very important. I'll not go in details of, usually PA and APB usually is done in children, and when patient is very sick, he cannot be positioned, you cannot ask him to stand. And especially if you see spine, then APB is ordered. Otherwise, most of the chest X-ray is done in PA view. Standard is PA view. And sometimes we advise lateral views. Lateral views nowadays rarely done, but yes, it still can be advised, especially in the teaching hospital. It is to localize the shadow. It first use of lateral views localize the shadow. Which lobe, which segment shadow is this? Then in a retrocardiac area, which is not visible in PA view, that may be visible in the lateral view very clearly. Localization of the ancestor diffusion, even mediastinal lesion, which mediastinum probably lateral view would be answered. So these are so if you want to localize, this is a lateral view. And then another view is done, rarely done today, but we still do it. This is a lateral decubitus view. Patient is lying down in a lateral position. And main indication is one of the infusion known as infrapulmonary effusion. And then another view is a lordotic view when patient stands like a lord or even the tube is being tilted. And that's the main indication of lordotic views, something lesion in the behind the clavicle and middle lobe collapse. These are the two indications where nowadays, although these things will be visible in the CT scan today, but if you want to do X-ray wise, then these are the indications. As you know, this lady Susila, I saw her in 93. Chest X-ray was literally a normal looking, but she was symptomatic. So we did lateral view. Even lateral view was not able to see anything in the lateral view. Those days, even CT scans were not there in KGMC. So we did this lordotic view, and lordotic view has shown a very typical triangular opacity. And if you read any textbook, you'll find such type of shadow for right middle lobe collapse. Middle lobe is a very small lobe. When it collapses, it becomes further small. So it is not visible in the PA view, not visible in the lateral view, but it very good typical X-ray will be seen in lordotic view. So that was the middle lordotic view and the middle lobe, right middle lobe collapse. I was talking about rotation. Rotation is find out when patient is not standing symmetrically and erect, then the rotation is method of rotation is you just draw a midline in the mid-spinal line and then see the medial end of clavicle on one side and then the other side, and with these things you see the distance. This distance on the right side is much more as compared. So patient is rotated on one side. And this rotation this is a left anterior oblique rotation to be very precise. And this rotation will produce what are the false findings. These are the pseudo findings. Anterior oblique rotation, heart and trachea may look shifted. Diaphragm may be raised. Hilar prominence may be on the same side, and lung field may become more hypertrophic. What I'm trying to say, if person is rotated, then it creates a certain fast finding, which is not there in fact. So the technique inspiratory and expiratory again, if the film is not done in a full inspiration, then heart may look larger. bilateral raised diaphragm should be there, and clouding of lung bases should be there. So what I'm trying to say, if these technical points are not followed, as I can see you, one of the X-ray, this lady, when X-ray was done, somebody diagnosed that she has a cardiomegaly, cardiac size is enlarged. But if you see very carefully, her diaphragm, 1, 2, 3, her diaphragm is at the level of 4th. So this is much higher. So patient has not inspired fully. So this film was done in expiratory phase. And when the same patient, when inspiratory film was done, you can see that heart size has become normal. So that is the importance of a technical issue. So you must realize that when you see, you must see that X-ray is done properly, and you have to do it. Is similar is not only for CT scan, similar is true for CT also. In expiratory film, there are a lot of shadows always. So those are the some of the technical points I tried to. Then these are the anatomical points I already say, starting from soft tissue to bony case, trachea, diaphragm, heart, hilum, mediastinum, fissure, parenchyma. Everything has to be looked systematically. And in a soft tissue shadow, you may see many issues, but absence of breast shadow can have a lot of implication in the diagnosis. You can subcutaneous emphysema. It is one of the very common X-rays during MBBS exam. It is shown that air in the subcutaneous planes. So these are the like you see that this is a lot of air in the subcutaneous plane, in neck, chest, everywhere. So this was subcutaneous emphysema. And then bony case also, and in bony case, every bony case like clavicle, ribs, intercostal spaces, spines, everything has to be looked thoroughly. And then one question is always asked, how to recognize the first rib? Unless you recognize first rib, you cannot count the ribs. And the first rib rule says, first anterior end just below the clavicle is the anterior end of the first rib. By this rule, this is the clavicle and this is the first, and the rib has anterior end and posterior end. Anterior end attaches with the sternum and posterior end goes to the spine. So this is the anterior end. Subsequently, you can count this is first, this is second, third, fourth, fifth, sixth. Like way, posterior ends also you can count. This is first anterior. This is the second anterior, the second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th, 11th. So this is visible in chest X-ray. So this is all numbered. They have been numbered. Diaphragm is also seen. Diaphragm, you have to see position, shape, angles, guess under diaphragm. This is under foreheading. Diaphragm may be normal, may be raised, may be depressed. All possibilities are there. And bilateral raised diaphragm, usually technical, as I said, if the film is expiratory, bilateral raised diaphragm would be there. And if something in abdomen, then both the diaphragms should be raised. Or bilateral fibrosis, again it would be raised. Raised diaphragm, unilateral, I usually say these are the 5 causes to our PG students, that something paralytic means involving the phrenic nerve, something mechanical like collapse and fibrosis, something developmental like eventration of diaphragm, spastic like something below the diaphragm can push the diaphragm, and infrapulmonary. These are the 5 reasons for unilateral raised tone. Many times in X-ray you see, and try to argue, try to find out what could be the cause of unilateral raised diaphragm. Diaphragm may be depressed, and bilateral depressed diaphragm, most common finding is chronic obstructive emphysema. Severe COPD, you find both the diaphragms should be depressed. As you see, this is the example of a very large lungs, and because of the the COPD, severe COPD, and so the diaphragms are depressed. Even so, angles, both the angles you have to look, castophrenic and cardiophrenic. One of the most dramatic example of castophrenic obliteration is pleural effusion. And then cardiophrenic angle between the heart and diaphragm you have to look for, and this could be collapse of the middle. There are many reasons for the cardiophrenic angle of it. Heart you have to look for position, border, size, shape. Main thing in radiology chest we see about the size of the heart. There are three methods to see size of the heart. Most common is a cardiothoracic ratio. You measure the diameter of the thorax maximum and then diameter of the heart, and that ratio should be less than 50% normally. You can measure the transverse diameter of the heart, that normally should be less than 15.5. And if you are comparing two x-rays, but believe me, these two x-rays must be identical. Not one is inspiratory, another is expiratory. So between the two identical x-rays, if the difference is less than 1.5 centimeter in transverse diameter, you can say normal. Otherwise, you can say that heart size. This is a way how we measure heart size, cardiothoracic ratio. And this is if you are interested, you can go on the YouTube. There's a YouTube lecture, my own YouTube lecture is there, how to measure the cardiothoracic ratio. And then you have to look for hilum also. And then these are the hilums, these are the two hilums. This is the cardiophrenic angle. This is the castophrenic angle. This is the diaphragm. So everything you can look like hilum size, position, shape, radiopacity, everything. It looks very easy to see the X-ray, but it looks like last time the hilum, normal, enlarged, maybe small in size. There are reasons. Unilateral enlargement, usually tuberculosis is very common. Bilateral enlargement, and when you see hilar enlargement, you must look before rotation. In a rotation, I still remember this patient came to me when one of the hilar enlargement, hilar shadow prominent, but there was a rotation, and this was we always check for rotation before commenting on the hilum size. So this is what is hilum, and then enlarged hilum may be bilateral. Bilateral hilum may be enlarged in expiratory film, and one of the commonest reason, maybe TB also, but commonest is sarcoidosis. This is an example of sarcoidosis. And then mediastinum also you have to look superior, inferior mediastinum, and then further anterior and posterior. Everything can be divided, and finally you go to look for the lung parenchyma. And in lung parenchyma is divided into zones for easiness point of view, and zone. How the zone is divided? You see that this is a first rib anterior, and this is a second rib. So lower border of the second anterior end of the second rib, you just draw a line, and same points on the fourth rib, you draw another line. That is how you divide upper zone, middle zone, lower zone on both sides. And then you do this film was expiratory. In expiratory, only upper and middle zone is visible, lower zone is not. That's why expiratory films are not. And then you go to the lung parenchyma. In lung parenchyma, you find many types of opacities like hemiopacity, translucency, infiltration, cavity, miliary shadows, nodular shadows, rounded shadows, calcified shadows. Every shadow you have to recognize, you have to. Like hemiopacity, there's a one rule which says homeopacity may be because of the effusion, because of the consolidation, because of the collapse. That is how the people say consolidation rule says consolidation means radiopaque shadow without any mediastinal shift is a consolidation. Radiopaque shadow with mediastinal shift on the opposite side, heart is shifted, is pleural effusion. Mediastinal shift radiopaque shadow with same side mediastinal, trachea is shifted, even diaphragm heart has gone there. It is a collapse and it may be fibrosis also. And then, so that is how. So what I'm trying to say, while you read the X-ray, read it thoroughly, read it properly, then you will be able to read it properly. Then my second part has come a chest X-ray presentation in pulmonary tuberculosis. When you talk of pulmonary tuberculosis and you talk of chest X-ray, I usually say it is a very, not me, everybody says it's a very sensitive. Even a smaller lesion you may detect, but it is not specific. Which lesion will be tuberculosis? Nobody. It is difficult. And then, but it identifies person early, and it talks about how investigation can be done in future. And one of the friend from USA, Dr. Atul Mehta, is a Cleveland hospital. He wrote one of the editorial, murder of the chest X-ray. Now people are now, I saw two patients yesterday. They have CT scan, but they don't have chest X-ray. That is how in 2011 he wrote from USA, murder of chest X-ray. This has already happened in USA, and this is probably going to happen in India also. But X-ray is although very, every time you cannot do CT scan. So you should read X-ray, you should know. And there's another study, our own study, which is published in the International Journal of TB and Lung Disease. If you really rely on chest X-ray alone to diagnose tuberculosis, you may do a lot of mistakes. You can diagnose anything as a tuberculosis. So that you should not do it. So another study I'm like to share with you, that disparity between chest X-ray reporting and actual. Now reporting has much improved. This study we did it 2006 or 7 way back when I was in KGMC. And there was a lot of disparity between reporting and a lot of technical issues we have detected. So that's why we say that if the X-ray is of poor quality, I usually say, my PG student, remember my dialogue, throw it into the dustbin. If the X-ray is not proper, don't try to read it. Otherwise, you will read it falsely. So now it has come how TB looks in chest X-ray. Common presentation in chest X-ray is like, you see, they are bilateral shadows. They are usually in the upper zone. I say usually in the upper zone.
हाँ चल रहा है बॉस नाम मेरा पता नहीं क्या है
Then
हाँ
there would be, again, if there's a cavity in that shadow, TB is very high. Then you see that bilateral, these are the miliary shadows, infiltrates, miliary shadows, although miliary shadows are not always miliary tuberculosis, but in India, miliary tuberculosis is very common. And this is a miliary tuberculosis in CT scan. This is a unilateral hilar lymph node enlargement. Cause was tuberculosis. This is the bilateral mediastinal lymph nodes. Like potatoes has been put here. Classical example of mediastinal lymph nodes. Again, it was found to be tuberculosis. And this is a pleural effusion, very common in India. Pleural effusion as a tuberculosis. This is the infrapulmonary effusion. This is again common in India sometimes as a tuberculosis. And this is, in the lateral decubitus view has shown that fluid has it. So this is a left-sided infrapulmonary effusion, rare finding, but sometimes you can get it. This is insisted pleural effusion. These are examples of all diagnosed tuberculosis and treated. This is again example of look like a mass, but you see CT, there is a fluid density that was insisted pleural effusion. So pleural effusion can present, and this is the one of the common is the hydropneumothorax. This is a fluid level, and this is a collapsed lung border. So this is an example of a hydropneumothorax. So these are the classical presentation how tuberculosis present in India in chest X-ray. Earliest finding, I must say here, that behind the clavicle you may get very few infiltrates. That would be difficult, but now with subsequent CTs and everything you may find it. So this is how and then another 2-3 minutes I'll take is how tuberculosis heals. That is also very important. Tuberculosis heals first by calcification. I know this lady, you have bilateral calcified shadows. If you take history, there will be long history of anti-TB. She has already received anti-TB treatment, but she presented with hemoptysis, massive hemoptysis. But this is because of the calcified. So TB heals by calcification. Then there is a cavity. How cavity heals, one should know. Cavity heals by two methods. One is the open method, another is a closed. Normally, cavity heals by closed method, where cavity disappears. You see in this case, there is a cavity here, and under the effective anti-TB drugs, its cavity has become small and finally has disappeared. This is known as a closed healing of a cavity. This is a good luck to the patient. But in about 15 to 20%, the cavity heals by open method. You know, thick wall cavity, after treatment, it has become a thin wall cavity, but this cavity will persist, and this is known as open negative syndrome. And one of the complications of open negative syndrome, hemoptysis, I know kilos and quintals of ATT are misused in such healed cavities. So you must remember that cavity may heal by open method. This is another example of open method cavity healing. This is how the pleura calcifies. This is a pleural calcification. This is healing of pleural. This is how the lymph nodes calcify. This is a lymph node calcification. This is how, again, how the empyema, they calcify. This is all examples of how TB heals. And then my third part, maybe another 5 to 7 minutes I'll take, that what are the common differential diagnosis of pulmonary tuberculosis, where I said in my introduction that kilos and quintals of ATTs are misused in such type of conditions where they mimic like tuberculosis. I'll give you 2-3 examples, very important examples. Now this gentleman, he's a lawyer by occupation, and he came to me, he was about 50-year-old male, lawyer I said by occupation, had a cough with copious amount of, find it copious, large amount of expectorant. For last 10 years, breathlessness for 4 years and recurrent hemoptysis for 2 years. When he came to me with for an opinion that he was a liar. He wanted to sue the previous doctors. I think 4 or 5 doctors treated him. I don't know, but he said that I have been treated for tuberculosis, but I have no improvement. My hemoptysis is recurring, cough and etc. But you see the face, in his face diagnosis is written. This was the smallpox marks. There's a corneal opacity also on the right eye. So that speaks that he's suffering from some respiratory disease. And we know that exanthematous fever is small, and although smallpox has been eradicated from India, but previously people may have suffered from it. So this marks has clearly indicating the diagnosis that he may not be tuberculosis. He may be case of something else like bronchiectasis. History is also suggestive of bronchiectasis. So you see that this was the X-ray shadow in the lower zone on the one side. Again, this is finding favoring bronchiectasis. Again, CT picture confirmed presence of bronchiectasis. And so what I'm trying to show, bronchiectasis is one of the DD which comes in tuberculosis, and many times lot of ATTs are being misused. This is another lady I still remember. I was head in KGMC. She came weeping in my room and, I said, why? Please sit down. What is your problem? She said, sir, I have no complaints, but somebody written me anti-TB drug. So I said to lady that yes, there are shadow. You can see, if you agree with me that this is a shadow in the left upper zone. I said there are shadows, it looks like tuberculosis. But she insisted on me that no, sir, I have no problem. Why anti-TB drugs were? हमने कहा, why did your X-ray done? She said, I had some cough, so the X-ray was done. So it may be tuberculosis. Anyhow, she insisted. So I got another X-ray done same time on the same date. Because I saw something in the patient and something in the X-ray. I'll let you know later on. So that was, that was the shadow on the 7th of July, 98. Same day the X-ray was repeated, shadow has disappeared. So it can't be tuberculosis. Although shadow were in the upper zone. And what was this? This was fleet of hairs. Hairs normally doesn't cause shadow. But in this lady, it has casted shadow because the way the hair was. She had a hair like this. So this has cast the shadow, and that I got some inkling in the chest X-ray. I'll show you if it is here. Yes, it is here. You see, when you see in this X-ray, and if you see shadow here and trace its origin, and if the origin can be traced, you see the larger film, if the origin can be traced outside the chest wall, rule says it is an extrathoracic shadow. That is how I suspected. And I just got X-ray done and got relief. The lady become very happy and said, so sometimes such type of things may happen. So you have to be very careful. And then this is another. I said cavity is very important for diagnosis of tuberculosis, but not every cavity will be tuberculosis. This about 14-year young boy had high fever, have cough with large amount of expectoration. At that time, sputum was negative. Gene expert were not done on those days. So I said, sputum is negative, such a large cavity. How it can be TB? So it was an pathogenic infection, Klebsiella pneumonia, which I think after 10 days of antibiotics, see the cavity has disappeared. So we need, and this is another. This is a lymph node. I said lymph node is very common in tuberculosis, but not every mediastinal lymph node. This was diagnosed. This lymph node has disappeared within 10 days of time. What do I say? Sometimes I was told in MBBS classes that lymphoma, Hodgkin's lymphoma, melts like ice. So it has melted with one course of chemotherapy. So that was a Hodgkin's lymph node. These are the mimic. This is another, looks like a cavity with fluid level, but it was eventuation of diaphragm. This is a congenital condition. Patient was asymptomatic, no fever at all, and finally diagnosed as, this is a congenital condition where left dome of diaphragm is rare condition, but it can give you see the another cavity. Somebody prescribed ATT with the presence of cavity, but after 2 months of treatment, cavity size has increased. And this is the characteristic CT picture of a malignant cavity. What I say malignant cavity means cavity is very thick wall. Cavity is eccentric, like eccentric personality. Cavity it is deviated on one side. And then inner linings are very irregular. If you read any textbook, you'll find these are the characteristic of a malignant cavity. And finally, a bronchoscopy was done and it was diagnosed as malignancy. Pleural effusion in India is another area where a lot of anti-TB drugs are misused. This 57-year lady had history of 40 BDs for 25 years, and then cough expectoration. So with smoking history, some pleural effusion, which has increased after ATT. When CT was done, you find there's a mass and effusion both. And then bronchoscopy was done. You find that there's a growth here. You can see in the moving film, growth is there from the bronchiole. So what I'm trying to say, not every pleural effusion is tuberculosis. This is another example of something like miliary shadows. And here the diagnosis was done as you see that this is the CT picture of miliary shadows I shown, but here eosinophil count is 48%, though it was diagnosed as tropical pulmonary. So these are the common features. Sometimes they come in a differential diagnosis of tuberculosis. This was diagnosed as tropical pulmonary. The another condition nowadays, this lady, I still remember, I saw her she's a lady of a vice chancellor somewhere in the year 2000, when I was in KGMC. She came with this complaint, dry cough and breathlessness 5 months. History is very typical, and this shadow was not there, any not very common, but somebody diagnosed, somebody put on anti-TB drug empirically for this shadow, cough and breathlessness. Clubbing was present. Clubbing is usually not a feature of TB. It is a feature of bronchiectasis and nowadays ILD result. And there was a bilateral inspiration. History and findings suggestive of, although in 2000, interstitial lung disease was not very common, but we were in medical college, we suspected, we diagnosed, and Savitri lady has become, that subsequently, there was a restrictive airway disorder, FVC was very low, and there was no obstruction. This or that was a typical CT features of IPF, idiopathic pulmonary. Those days, quality of CT was not much as it is today. So she was diagnosed IPF, and IPF is like a lung cancer, and ultimately she died. So what I'm trying to say, these are the different. This is another, somebody has a multiple shadows, but if you see the X-ray carefully, you find that left breast is there, right breast is not there. So one breast was removed. I asked the lady, did you undergo any surgery? She said, yes, my breast has been removed because of something, see a breast. And with this, do you find these nodular, which looks like a tuberculosis, but it was secondaries with the CA breast. So another last patient, I think this is another patient, Gaurav Jain, a very rich man, about young man, had about 6 months of ATT because of some hemoptysis, but he also had a breathlessness. And I don't know where was the tip, but he was some shadow doubtful. When he received 6 months of ATT, his shadows has increased. So the previous doctor treating him, he said, now you have a drug resistance because you have not responded to 6 months of anti-tubercular drug, regular anti-TB. And this was the previous film, and this is after 6 months. Even these two X-rays are shown to me. I'll also say yes, TB has increased. But when the first investigation, when he came, actually he wrote drug for drug-resistant TB, but he was very smart. He said, no, go and take opinion of Dr. Prasad, and then you start this drug-resistant TB. When he came to me, I did see sputum for AB. Those days, gene expert not available, so they're negative. I said, if such an extensive lesion, sputum is negative, it can't be TB. It is something else. And where are the indicators of something else? You see, eosinophil count is 30%. That was the indicator one. Then we investigated him thoroughly for skin test for Aspergillus antigen, total IG and IgG against Aspergillus. They are all high and proven. And ultimately, skin test positive. CT picture was also typical of a condition, what we call it as as allergic bronchopulmonary. It is an allergy to fungus. And this is not very rare condition. And when patient was treated properly, everything has subsided. So what I'm saying, these are the, and you know, this is the diagnostic criteria. Every diagnostic criteria was met in this particular patient. And this is a latest guideline. But so what I've come to, so what you see that in differential diagnosis in India, large other non-tuberculous condition, they are diagnosed. What cases I have shown, they have already received many times anti-TB drugs. So they mimic tuberculosis. So that is why I said that radiology may be very sensitive, but it is not specific. When I was lecturer way back in 80s, I used to tell that my students, if find cavity, find this, chances of TB was very high. But if you ask me today, after about more than 45 years in this specialty, I say none of the shadows can predict tuberculosis. So you have to be careful. So my concluding thoughts have come, and I would say I will use 2-3 slides in concluding thoughts. I always say that don't treat investigation in that lady where X-ray was showing shadow, but it is because of the hair. So I always say don't treat investigation. Treat patient as a whole. Patients insisted on me, sir, I had no problem, no symptom. Still I said you may have tuberculosis without symptom. But then I investigated and was rewarded. So that is always say that we don't treat investigate, treat patient as a whole. And any investigation don't be dictated by them. Investigation, I always say, if I as a clinician can do wrong things, sometimes happen with us, why the labs cannot do wrong things? Error may occur in labs also. So please don't be dictated by them. I can talk for hours and hours together how the different investigations from different labs. This is day-to-day clinical observation. So that's why I said this is my famous dialogue during my undergraduate classes. Don't be dictated by any investigation. Take them as advisor and friend along with other details of the patient. You have more large other details. So you combine everything, then you treat the patient, you'll be very comfortable. And finally, when I'm talking about X-ray and TB, I say this slide is very important. That when you read chest X-ray, I always say that single X-ray may not be sufficient. Think of other views. Suppose patient has done X-ray before, you ask the patient to bring that. Think of other views. One view may not be sufficient. Think of old X-rays. Story always goes with my PG students. They say always, sir, patient says that iske X-ray sab gayab ho gaya, chori ho gaya. When I go to the round sometimes and they say I have many X-rays with my, so please believe the old X-rays that can help you a lot. Ask your patient to bring that. Think of other radiological. X-rays are not panacea. Everything you cannot find out in the X-ray. Sometimes you have to do others like CT, other investigation. Think of other investigation. You have to do other, and ultimately, if you are still not be able to clear, think of clinical picture. That is a very important. I have shown you 2 cases where one was bronchiectasis, another was Klebsiella pneumonia. Think of their clinical picture, high fever, large amount of expectoration. How it can be tuberculosis? Very rarely. So that is ultimately, I say, if you only want to, so my final take-home message to all of you who are listening is that whenever you read the X-ray systematically. Think about all the finding, technical and the anatomical finding, and combine all those findings. Then try to interpret, and then in interpretation, these things, older X-rays and other views, other investigation, and finally, the clinical history means history and physical examination. also comes to your rescue to think about the proper diagnosis. With this, I think, as I said, we have written many books. This is 100. Some of the cases that I shared was written in this textbook. 100 cases in pulmonary medicine, adverse drug reaction in TB treatment. We have 4 books on tuberculosis by this time. We have book on allergy. We have Atlas of Fiber Optic Bronchoscope. And then we have many more YouTube lectures, many of the PGs, if you are interested. You can listen how to take history, how to do physical examination, how to do auscultation. And I will end my lecture by sharing 2 more slides, which are very important, I believe. A doctor is a student till his death. When he fails to be a student, he dies. So please read, read and read and read. And these words are said very long back by a very famous clinician, Sir William Osler. His name is very popular. And so, and then I say one more word. Medical science is a fast changing science. If you don't read, you will not be able to successful clinician, successful doctor. And before I say thank you, I'll say to another quotation for younger people like you, that anyone, there's another advantage of learning, keep on learning, is anyone who keeps learning stays young. So please believe in these statements and keep on reading. My best wishes to all of you, and I say thank you. And that's why in my slide, in my last slide, I don't know, it is not coming, but it always comes that I am still learning, that people like it. So thank you very much, and once again, and if you have any question, and I love to answer those questions, provided I can answer those. So I'll just unshare my slides before I stop share. Yes, I'm here. Thank you,
Thank
sir.
you very
Thank
much,
you.
sir,
Thank you.
for the wonderful lecture. This topic, though very, very important for all the doctors, this was made very easy by you. So, hope that all the people who are attending this lecture through Zoom or through YouTube, they will start the systematic approach, and soon they will be able to adopt that global approach of viewing X-rays. So that's really nice of you presenting this lecture so simply. So, sir, one query that has been written on the YouTube: how to differentiate perihilar opacities from lymphadenopathy, or mainly tubercular lymphadenopathy, or maybe other infective lymphadenopathy?
I think a very intelligent question somebody put. How to, please repeat this question, Dr. Jaswan.
Sir, how to differentiate perihilar opacities from lymphadenopathy?
Also, it is very difficult thing, but only thing that if you do a valsalva maneuver, but those X-rays will be difficult. But lymph nodes is a very different in look, and the perihilar shadows may have multiple things. So ultimately, X-ray sometimes you may not be able to find it out. Ultimately, probably you have to do another investigations like CT scan may be very clearly spell that what is the cause of this perihilar shadows. Perihilar shadows may be lymph node, maybe mass even can present like a perihilar shadow. Maybe vascular shadows may be there which can present as a perihilar. So difficult area in the at least in the chest radiology.
Right, sir. Thank you, sir. Sir, as you told that mainly we learned uh, reading the X-rays. So apart from X-ray, we also have other modalities like plain chest CT, then contrast enhanced CT of chest, then HRCT of chest. So another question is just related to the imaging. Are MRI of chest or lung are done? And if it is done, then what are the indications for MRI lung or chest?
You know, the main radiological investigation in chest medicine is chest X-ray and CT scan. And you already said that CT scan can be with contrast, can be without contrast. And without contrast, usually most of the CTs are done without contrast. Contrast is usually done if you are seeing a malignancy. Sometimes you want to see a lymph node, you want to differentiate from vessels, then probably contrast is given. MRI as per se in a chest medicine has a not very important role to play. But there are 2, 3 situations which I can imagine. If there is some like a Pankos syndrome, involvement of nerves in there, probably that can delineate much better way. But most of the things can be even known by the CT scans. So MRI has not a very important role to play in a chest radiology.
Right, sir. Sir, thank you, sir. Sir, another thing that you very importantly highlighted that it's always wise to treat the patient as a whole, not the investigation. So, like if in cases, there are cases where there is high suspicion of tuberculosis on X-ray, but the sample comes negative, like mainly AFB staining. So AFB stain, once done in periphery, there might be issues in sample collection or other maybe the once they are carrying it or once they are making slides. So other human error may occur. So, like in those cases, a clinician should start ATT after viewing X-rays, or like they should wait for the confirmation through AB stain or other cultural modalities.
Doctor, you put a very important question. You know, if you see the classification of tuberculosis today, you have got 2 types of tuberculosis, essentially. One is the microbiological proven tuberculosis, where you said yourself that whether it is proven by microbe, say smear for AFB, culture for MTB, or by molecular biology. Now there are a lot of newer investigations. You have come, Gene Expert, TrueNat, and then LPA, LPA1, 2, many things have come up. So this is all, if it is confirmed by any one of them, this is known as a microbiologically confirmed tuberculosis.
Right, sir.
The another type of tuberculosis, the case you referred, is probably clinically diagnosed tuberculosis. So if your suspicion is very high and you believe that it could be tuberculosis, and the next breath you must also think that there are other common diagnoses you have been able to exclude, then you are justified to write anti-TB drugs without being confirmed by microbiologically or in spite of your best effort. Although there are large number of other efforts, you can do bronchoscopy, you can do, but everything is not possible everywhere. But so in otherwise your question whether one can put on ATT, yes, on a clinical grounds also, If I always teach two things. If your suspicion is very high, yes, it is tuberculosis. It may be tuberculosis. And second, you try to exclude other common differential diagnosis. If it suppose somebody has malignancy and you are saying it could be tuberculosis, and then if you give 6 months of TB, the malignancy will go into stage 4. So that is why the exclusion of other common etiology must be excluded. Then you have all right to justify. We say that TB treatment can be given on a clinically. When I say clinically diagnosed, it is not been proven by microbiologically or molecular biology. So I hope I am able to answer. This is a very difficult area. But
Sir.
yes, one can write. Nobody should die of tuberculosis today. Unfortunately, many people are dying because of the late diagnosis. And
Right.
a very, very big issue has come up. Diagnosis is very late. So if you are suspecting tuberculosis, you are not able to prove it, and you say that yes, it may be TB, you can go ahead with the treatment.
Right, sir. Thank you, sir. Thank you very much. One of the attendee, one of the participant, they asked regarding recording of this lecture. Yes, all these lectures are being recorded and are being uploaded on the NAM's website. One can visit the website and they can watch the lecture. They can listen to the recordings. So next question is regarding latent TB, sir. So
Yes, latent
yeah,
TB.
it
Yes,
is
go
being
ahead.
asked, what is latent TB and does it need to be treated?
Latent TB, you again open a Pandora box. So latent TB is, TB means person is infected by Mycobacterium tuberculosis, but that infection has not developed a disease. That is what is the actual meaning of a latent tuberculosis, right?
Right, sir.
And in our time, when I used to teach MBBS student way back in 80s and 90s, then I used to tell them, yes, this is a one way of preventing tuberculosis and control of tuberculosis. But choice was not there at that time, because at that time, main emphasis was on the treating tuberculosis. But now in the current situation, we have a lot of preventive treatment also. Means person who are infected, but they have not got disease, it means you have to exclude the disease in them. And now the anti-national TB elimination program already has one component of TB elimination as a preventive therapy. And in preventive therapy, a lot of new things have come. In our time, preventive therapy was 6 months to 1 year with single drug like isoniazid. Now there are drugs with, say, rifampicin and isoniazid, once a week dose, 12 dose for the 3 months. So the duration has been reduced with the newer drugs, and yes, there are evidence that preventive treatment can also help in eliminating tuberculosis. So now there are in country, in our program, preventive treatment is being used by the government.
Thank you, sir. Although this question was not related to today's theme, but it definitely enhanced our knowledge. So the next question, okay, so we have also provided the recorded lecture link. I request the participants to write the questions, or if anyone is slow in typing, so now they can request to unmute themselves and then they can ask the question. They can just raise their hand and we can unmute them from our side, from admin end, and then sir, okay. Sir, I think there are no more questions. So this was indeed a interesting series, I would say, including today's lecture. So this whole series, the complete series is going to benefit a lot of people like us who are like new to this field, and also many medical officer who are serving in the periphery, also many students who are preparing for the entrance. So I would like to request Professor Ajay Kumar Sood sir for the word of thanks.
Thank you so
Over
much.
to you, sir.
Before Dr. Sood, I had one very small query to Dr. Sood.
Sir.
Sir, I am audible?
Yes, sir.
Yes, sir.
Like these, I know that these lectures are being recorded. So how I can get these lectures? Can I also get these lectures separately? That is my.
Yes, sir. Yes, sir. We can send you the link, sir. You can
Thank you.
always
Thank you.
report the link. Yes,
Thank you, sir. My all the 4 lectures, I believe,
yes,
if
sir.
you can.
Sure, sir. Sure. It is our privilege, sir, to have you here.
Thank you,
And
sir.
thank you so much, sir, on behalf of the National Academy of Medical Sciences. Once again, we are really grateful to you, sir, for taking this series. As Dr. Jaswant said, it has benefited all of us, especially our PG students. And the way you have explained in all these 4 lectures, I think everybody has really appreciated your efforts as one of the best teachers. I must say that one of the best lecture ever we had on this program. By quoting your experiences and also giving case studies and scenarios. So thank you so much for your support to the Academy. And all these lectures, as Dr. Jaswant said, are available online. So those students who have missed these lectures, they can always refer to NAM's website, and they can even download those lectures for viewing again and again. Once again, thank you, and we look forward for your continuous support to the Academy. I would also like to thank all the participants, or faculty members and junior faculty members, senior faculty members, as well as the PG students who have attended this series and asked questions and made this session very, very interactive and important for all of us. Thank you so much. Special thanks to Dr. Jaswant, who has been always helpful and coming forward for moderating this session. Here in the NAMS Academy, we have our IT team headed by Mr. Ravi, as well as Mr. Shivam, who has been helping us in organizing this session. And they have also writing to you and communicating to you about the details. So once again, thank you so much. And for the students, the next session in the series on 1st of August, where we are going to cover a very interesting session in ophthalmology, where the experts are going to discuss on surgical management of glaucoma. So I request all the participants to communicate this information. And we have shared the details of all the lecture till December 2025 in the chat box, and also the name of the experts who are going to take it. So if you have any questions, you can always send us your question, and we'll try to communicate these questions to the experts in advance so these can be answered. So once again, thank you so much for being with us. Over to you, Dr. Jaswant.
Thank you, sir. And thank you, sir, again.
Thank you. Thank you very much to all.
Thank you, sir. So now we can conclude the lecture, sir. Thank you, sir.